Hi, good afternoon everyone. Today's lecture is about the equipment and instruments for the basic oral surgical procedure. My name is Al-Marashi. I hold an MSc degree in oral and maxillofacial surgery from the University of Manchester. I'm a lecturer at the University of Basra, College of Dentistry. In our lecture, we'll imagine ourselves doing an oral surgical procedure. So following the administration of a local anesthesia to the patient, for an invasive oral surgical procedure, we'll start by incising the soft tissue. Then we'll imagine ourselves elevating a flaps. So we need to elevate a mucoperiosteal flaps. We need to retract the soft tissue, retract the flaps, and if we encountered any hemorrhage, we need to control it. Sometimes in oral surgical procedure, we need to remove bone. Sometimes we need to remove soft tissue from bony cavities. In a prolonged procedure, sometimes we need to keep the mouth open during the procedure. And in order to increase the visualization, we need to suction the blood and the fluids from the oral cavity. Sometimes we place towels and drapes around the patients and need to hold them in position. And in certain procedures, we need to use irrigations. And following the completion of the oral surgical procedure, we need to suture the area and close it. So we'll discuss the suturing instruments and the material we use for the suture. Starting with the first part, which is incising the soft tissue. Incising the soft tissue can be done by several instruments. The first one, which is most commonly used, is the scalpel. The scalpel is composed of a handle that can be sterilized and used again and again, and interchangeable disposable blades. The handle, there are different types of handles. The most one that being used is Bart Parker number 3. This is the most common handle used in oral surgical procedure. We are different blades that can be fitted on this handle. Can be either blade number 15, blade number 12, and blade number 11. Blade number 15 is the most common blade we use in oral surgical procedure, which is similar to blade number 10 that's used for skin incision. In order to load the handle with the blade, we need to grasp the blade with a needle holder and then slide the grooves on the slot that is on the handle. Until we hear the blade clicks on the handle, then it's fixed in position. Another instrument that can be used for incising the soft tissue is the dissecting scissor. The dissecting scissor usually have a blunt ended, and sometimes it's straight or curved. It can be used for separation or dissection of tissue from different anatomical planes, and also sometimes can be used for trimming of the flaps. So it can be used also for the cutting. Following the incision, we need to elevate the mucoperiosteal flap from the underlying bone. This can be done by periosteal elevators. The most common periosteal elevators we use in oral surgical procedure is Molt number 9 periosteal elevator. A Molt number 9 periosteal elevator is a double-ended instrument. On one of the side, we have a pointed end that can be used for the beginning of the elevation and for the reflection of the delicate papilla. And also we have on the other end a broad side that can be used for the continuation of the elevation and sometimes for the retraction of the flaps. Following the elevation of the flap, sometimes we need to retract the flap, or sometimes we need to retract the soft tissue, the lips, the cheeks, the tongue. This will give a better access for the oral surgeon and will also aid in increasing the visibility of the surgical site. We have different types of the retractors. We have retractor that designated for the use for the retraction of the cheeks and the flaps. So it can be referred as a cheek and flap retractors. There are different cheek and flap retractors. We have the Austin right angle retractor. We have the Langenbeck rake retractor and the Minnesota offset retractor. As the name implies, it will refer to the shape of the instrument. So Austin right angle, it has a right angle between the two parts of the retractor, and the Langenbeck rake retractor have the shape of the rake. While the Minnesota offset retractor, it has one of the end being in an offset from the long axis of the handle. So this is the long axis of the handle, while the beak of it is an offset away, a little bit away from the long axis of the handle. So we have the Minnesota offset retractor, Langenbeck rake retractor, and the Austin right angle retractor. Another type of retractors are the tongue retractors. The most common instrument that can serve the purpose of tongue retraction is the dental mirror, the one that we use during the examination. So a dental mirror can be used for the purpose of retraction of the tongue. And also we have the Weider broad retractor, which has a broad end that can be used for the retraction of the tongue. Sometimes another instrument that we will discuss later can be used for the retraction of the tongue, which is referred to as the towel clip. Flap retractors, on the other hand, this can be used for the retraction of the flap after being elevated from the underlying bone. We have either the sealed-in retractor, which is just a straight retractor that can be used for the purpose of the flap retraction, or we can use the same instrument that we used for the elevation of the flap, which is the Molt number 9 periosteal elevator. The broad end of the periosteal elevator can be used for the purpose of flap retraction. Sometimes we encountered with bleeding during the oral surgical procedure. The bleeding might be from small vessels, which can be controlled by applying pressure on the area. Pressure can be means of pressure packs using a sterile gauze we placed on the area, press it for a period of time, and then the bleeding will stop. But if we incised larger vessels during our flap incision, then pressure packs by its own will not be enough. We need to use another instrument to stop the bleeding. We can either use a hemostat, which is an artery forceps, also can be called as an artery forceps, which comes in different sizes and different shapes. All in common have a locking handle. So once you clip the instrument on a vessel, the instrument will have a locking mechanism in this position that will keep the instrument closed. The beaks of the artery forceps can be either straight or curved, and sometimes it can be long or short. The most common hemostat or artery forceps that's used in oral surgical procedure is the mosquito, which is a small, curved artery forceps with the locking mechanism. The hemostat, when placed on a vessel, will temporarily stop the bleeding, because once we remove the hemostat, the bleeding will recur from the blood vessels. Here we can see a magnified picture of a blood vessels that have been clipped by an artery forceps. So if you imagine us remove the artery forceps from the bleeding vessel, then the bleeding will recur. The blood vessel will be collapsed when we apply the hemostat and will return to its shape once the hemostat is removed. Another way to permanently stop the bleeding is by passing a suture around the blood vessel. Passing a suture around the blood vessel is called ligation. Another instrument that can be used also for permanent stopping of the bleeding, permanent hemostasis, is the electrosurgical unit. Electrosurgical unit can do cauterization by utilizing electrical current that is transferred into heat when applied on the blood vessels. By this instrument, we can permanently stop the bleeding. In some oral surgical procedure, like removal of impacted teeth, we need to remove bone. Bone removal can be done by different instruments. We can use a rotary instrument, which is the surgical handpiece on bone bears. The surgical handpiece will deliver high torque and high speed without using air. The surgical handpiece have different bears that can be fitted on it, which can be used for the removal of bone. We have round bears, Fisher bears, large bears, and small bears. All will be fitted on the surgical handpiece and aid in bone removal. The surgical handpiece requires irrigation during its usage. Sometimes we have large bears similar to acrylic bears, the one you use in prosthetic dentistry, which can be used for removal of large pieces of bones like tori, mandibular tori. Another manual instrument for bone removal is the rongers or bone nibblers. The bone nibblers can be either have only cutting end on its side, or sometimes it has a cutting end on the side and near the end of it. All bone forceps, bone nibblers, have a spring mechanism between the handle. The spring mechanism will help for restoration of the position of the handle once the pressure is removed from the handle. So if we press the handle, the ends will close, and once we release the pressure, the original position of the handle and the beaks will restored by the spring mechanism. Another way for bone removal is by using a bone file. A bone file is a double-ended instrument that have parallel grooves. These parallel grooves are set in an angle that only can be activated and only can remove bone when we pull it. The bone file can only remove tiny pieces and can be used for smoothing of the bone that have been cutted by another instrument. Another instrument for bone removal is also a manual instrument and is referred to as the chisel and mallet. The mallet is similar to a hammer. It's a heavy instrument. Their ends usually covered by plastic or a lead that will act as a shock absorption during the activation of the chisel. The chisel, on the other hand, is a sharp instrument that can be activated by hammering it, tapping it on its end by the mallet, while the working end will be placed on the bone and can be used for bone removal and bone splitting. The shape of the end of the chisel can be different, can either be monobevel or bibeveled. The uses of the chisel and mallet can be used for removal of large pieces of bone, for example, a tori. And as we said, the chisel is placed on the bone and tapped by the mallet in order to activate it. The last instrument that can be used for bone removal is the piezoelectric bone removal system. This is one of the newest devices that can be used for bone removal. It utilizes high-frequency vibrations for bone removal. The advantage of this instrument is that it can give more accurate cutting with less heat generation. It is safer to be used near vital structure like the maxillary sinus and the inferior dental nerve. The reason behind this is because the piezoelectric bone removal system, when uses a high frequency vibrations, it needs a hard object to cut that can't be vibrated with the same frequency. For example, if we place it on a bone, the bone is something that's a little bit hard and can't vibrate with the same frequency, so the sharp end of the instrument will cut it. If we place it on something that is soft, like soft tissue, for example, the lining of the maxillary sinus, or a nerve tissue like the inferior dental nerve, the soft tissue will vibrate with the same frequency. So this instrument will not be able to cut a soft tissue. While if we place it on something that is hard, that can't have the same vibrations, the same frequency of vibration, so the instrument will not be able to cut it. There are different inserts, different tips that can be fitted on this device. Some, like this, have a sawtooth that we can use for cutting of the bone aggressively, and other will be similar like bears with diamond coat on it. The diamond coat will prevent the injury of the maxillary sinus and the inferior dental nerve. Removing the soft tissue from bone cavities, for example, if we have cyst or granulation tissue at the tip of an extracted tooth or at the end of a socket, can be removed by using a surgical curette. As we said, it can be used for removal of granuloma of small cysts. The shape of this instrument is a metal double-ended with double angulation. So we have an angulation here, double angulation within the shank, and the tip of it is spoon-shaped. The surgical curette is different from the spoon excavator you use in operative dentistry. The surgical curette can be used for removal as we said, of soft tissue from the bone. The double angulation will aid the instrument to reach deep within the sockets. For a prolonged procedure, we need to hold the mouth open, and sometimes the patients can poorly cooperate with the dentist or the operator, for example, being sedated or having a trismus. Mouth can be opened during the procedure by using bite blocks, which is just a piece of rubber, or by using a side action mouth probes. The bite blocks, as we can see here, come in two sizes, a large one for the adult and a smaller size for the children. Both of these have a serration on its side that will engage on the cusp of the teeth to prevent the slippage of the bite block. And also it has a hole on one side of it, so we can place a suture or a gauze, long piece of gauze, to prevent the inhalation of this instrument. A side action mouth probe, it has a beak that is covered usually by rubber and a locking mechanism. So once we place it within the oral cavity and we press the handle, the locking mechanism will prevent the instrument from being closed again, and it will keep the mouth open during the procedure. The side action mouth probe can open the oral cavity to a greater extent what the bite blocks can do. Suctioning, sometimes during the oral surgical procedure, blood, saliva, and also irrigation fluid will accumulate within the oral cavity. So in order to increase the visibility of the surgical site, suctioning can be used. Suctioning utilizes negative pressure to remove these fluids from the oral cavity. We have different suction tip. Either we have a stainless steel, surgical grade stainless steel that can be used again and again, or sometimes we have a disposable plastic tips. The small diameter of the suction tip will aid in the rapid evacuation of fluids from the oral cavity. Sometimes we have an extra hole on the handle that will help in controlling the speed and the force of the evacuation. So if we close the handle with our finger, the hole in the handle, all the negative pressure will be directed from this hole. But while if we leave both of these holes open, the negative pressure will be distributed between these holes. So less fluids will be evacuated from the tip. If we close the hole, all the negative pressure will be directed through this tube, and all the fluids will be removed more rapidly from the end of the tip. If we use towels and drapes, a towel clip can be used for securing those around the patient. A towel clip also have a locking mechanism within its handle, so once we close the instrument, it will remain closed when we release the pressure by the locking mechanism. The beaks of the towel clip can be either pointed or rounded. The towel clip sometimes can be used for holding the tongue during biopsy taking for tongue retraction. Irrigation, on the other hand, irrigation can be used when we have bone cutting, or sometimes can be just used for washing the area to increase the visibility. If we have a bone cutting instrument, the benefits of irrigation will be cooling down the burr during the cutting, and also it will wash away the bone chips from the flutes of the burr. It will act as a lubricant agent for the surgical handpiece for the burr during the cutting, and also can be used for cleaning the area before the flap closure. Cooling down the burr is very important during bone cutting, as when the heats build up, the bone might undergo necrosis. So the irrigation will prevent the heat from building up during the procedure. The irrigation can be either by using a simple disposable syringe, plastic syringe, or sometimes by using an irrigation system. Certain surgical units, the one that we use in implant dentistry, for example, have a dedicated irrigation pump that will deliver continuous irrigation throughout the procedure. The last part of our lecture will be about the suturing instruments and material. The suturing instruments and material can be subclassified into the needle holder, the suture cutting scissor, and the tissue forceps we'll discuss later on, and the suture material itself. The first part is the needle holder. The needle holder is the instrument that can be used for securing the needle during the suturing of the flaps when we want to close it. The needle holder in general might look little bit like the artery forceps, but there are certain features that can we use it to differentiate between the needle holder from one hand and the artery forceps on the other hand. The needle holder in general, when we look at it from the outside, and the artery forceps will both have a locking mechanism. But the needle holder, the beaks of it, it's a little bit shorter and wider. So this is a needle holder that have a short and wide beaks, while the artery forceps, if it is not curved or sometimes curved or straight, it has a narrow beaks that is a little bit longer than the needle holder. If we open the instruments and have a look from the inside of the needle holder and the artery forceps, the needle holder will have a central groove on its beak, and the grooves on the whole beak is like cross hatches. So we have like an X grooves along the beaks, the inner side of the beak, and also a central groove that runs along the length of the beak. While the artery forceps doesn't have this long groove that runs on the beak, and the grooves runs on it in a horizontal position that's being parallel to each other. So the needle holder have a shorter, wider beaks, a groove in it, and the cross hatches, while the artery forceps has a longer beaks, narrower, and the grooves is parallel running along the inside of the instrument. Having a cross hatches and this longitudinal groove on it will aid in stabilization of the needle during the suturing. Another instrument that can be used for suturing is the suture cutting scissor. A suture cutting scissor have a curved tip that will aid in insertion of the scissor beneath the suture to cut it without causing too much discomfort. The next part of the suturing instruments and material is the surgical tissue forceps. The surgical tissue forceps can be used for stabilization of the flap as the needle passes through them. So as we said, it can be used for grasp of tissue. There are different types of surgical tissue forceps. We have a long one that is referred to as the standard tissue forceps. And we have a shorter, delicate one that is referred to as the Edison tissue forceps. Both of these instruments, their beaks sometimes have projections and sometimes can be smooth. So both of these instruments can be referred to as a toothed and non-toothed tissue forceps. If it is a toothed tissue forceps, then we have a projection and a receptor on its end. If it is non-toothed, there will be no projection and no receptors on the beaks. This is a magnified view on the beaks of an Edison tissue forceps. This is a toothed tissue forceps that has a projection on one side and a receptor on the other side. Having a projection and a receptor will aid in stabilization of the flap during the suturing. While if we don't have this projection, will be a non-toothed tissue forceps that have smooth beaks. Sometimes we grasp the tongue during biopsy taking. We can use a towel clip or by using an instrument that calls the Ellis tissue forceps. The Ellis tissue forceps have multiple tooth projections and a locking mechanism. The Ellis tissue forceps can only be used for holding the tissue that is intended to be removed from the body because it will crush it. So Ellis tissue forceps can't be used for holding the flaps during suturing because it will crush the flap during its usage. Another instrument that might look similar to the surgical tissue forceps is the college tweezer. The college tweezer is part of the diagnostic instruments and can't be used for surgical procedures. It can be used during surgery to picking up small objects from the mouth like fragments of the tooth, amalgam restorations, or foreign materials, and also for replacing and removing gauze, but should be never used for using as a tissue forceps for holding the flaps during suturing. The last part of the suturing material is the suture material itself. The suture material can be classified by different classification. This can be classified either as being resorbable or non-resorbable, can also be classified as being natural or synthetic, or can be classified as monofilament and polyfilaments. A resorbable suture is the suture that tends to resorb by its own and doesn't need to be removed from the body, while a non-resorbable suture will remain in the site and need to be cutted following, for example, 7 days or 10 days following the procedure. A non-resorbable suture, we have the silk, for example, while the resorbable suture, we have, for example, the BDS suture and the vicryl suture. Catgut is another resorbable suture. Non-resorbable suture, on the other hand, we have the silk, nylon, prolene, and also the surgical steel suture. These all are non-resorbable sutures and needs to be cutted and removed from the body. As we said, another classification is natural and synthetic. For example, the silk is considered as a natural suture, while, for example, the vicryl is a synthetic material. The nylon suture is also a synthetic material. A monofilament or a polyfilament suture would refer to the composition of the suturing material. If it is composed of one filament as a whole, this is a magnified view of a suturing material in a cross section. So if the suture material is composed of one filament, is referred to as polyfilament, monofilament, sorry. If the suture is composed of multiple tiny filaments that is combined together to form the suture material, then it's referred to as polyfilament. A polyfilament can be either braided, like this one, or twisted. There are certain differences between when we use a monofilament suture when compared to polyfilament suture. For example, in note security, when we tie a monofilament suture, the monofilament suture will have a smooth end. So once we tie it, the smooth end might slip on its side and the suture might become untied within time. While a polyfilament suture have a rough surfaces from the outside, and once we tie it, the friction from the rough surface will keep the suture tied together. Infection. A monofilament, as we said, has a smooth surface, so it doesn't harm a bacterial growth. While a polyfilament, since it's composed of multifilaments, there is spaces in between those filaments and can sometimes harm bacteria and form a nidus of infection. In addition, having a polyfilament suture sometimes tends to wick fluids. Wicking fluids means absorbing fluids from the oral cavity and sometimes can deliver those fluids with the bacteria within the surgical site. While a monofilament doesn't have this wicking action, so it doesn't absorb fluid. Passage within the tissue. A smooth monofilament suture will have easy passage within the tissue. while the rough polyfilament suture will cause some resistance during the passage within the tissue, and it's referred to as tissue drag. Traumatization from the suture end. So once we tie a suture and cut it, the monofilament will have a stiff end and sometimes tend to traumatize the nearby tissue, for example, the tongue or the cheek. While the polyfilament will usually have a smooth end and doesn't cause this trauma. The suture material come in different sizes. The size is referred by the diameter of the suturing material, can be designated by O. The O would be our baseline for size reference. The more O we add, for example 2O or 3O, the less diameter of the suture. So more zeros or more O's we add, 3O, 4O, 6O, that means we are decreasing the diameter of the suture. For example, a 6O suture will be smaller than a 2O suture. On the other hand, the less O we give, then the diameter is being increased. For example, a 3O suture, when compared to 0 or an O suture, the 1O will have a larger diameter. This is 0, and sometimes we have even larger sutures when comes as referred as 1, 2, 3. The needles can also be classified. For example, if we have a look on the cross section of the needle, it can be either rounded, an oval, or triangular. All of the needles that can be used during suturing made of surgical grade stainless steel. The rounded and the oval needles are referred to as non-cutting needles or atraumatic needles, while the needles with the triangular cross section can be referred as traumatic needle, can be either as a cutting when have one of the apex of the triangle, one of the cutting edges on the runs within the inner side of the needle. If we have the base of the triangle runs within the end of the needle, within the inner side of the needle, then it's referred to as a reverse cutting. Each side of this triangular cross section is a cutting edge. So as we said, if we have the apex of the triangle, we have one of the cutting edges runs within the inner side of the needle, then this is a cutting needle. If we have two cutting edges that runs within the inner side of the needle, then this is a reverse cutting needle. Also, the size of the needle can be subclassified in comparison to a whole circle. So we have a 1/4 of a circle, we have a 3/8 of a circle, sometimes we have half circle or 3/4. So the needle size can be either 1/4, 3/8, half a circle, and or 3/4 of a circle. This is all what we have for our lectures. If you have any questions, please feel free to answer them on the chat, and I will try to answer as much as I can. Thank you.